All right. Well, welcome everybody to the Cancer Patient Lab. We are excited to have our special guest, Nasha Winters, who is very unique, I think, in terms of the number of speakers or the types of speakers that we've had at the Cancer Patient Lab. She was diagnosed with ovarian cancer at the age of 19. She is had an exceptional response, and she's been, I think, free and clear of cancer. Um, Ever since. She's a nationally board certified naturopathic doctor, is also a fellow of the American Board of Naturopathic Oncology, and the executive director and co-founder of Metabolic Terrain Institute of Health. So we're going to be approaching this from an integrative medicine perspective. We're not going to be talking about, probably less about transcriptomics or genomics or proteomics or functional testing. We're really going to be talking about this from a complementary perspective. And so I'm interested in this for sure. So we're excited about that. Remember that this is not medical advice, that we want you to consult your doctor. This will be recorded and made public. If you don't want to be known in this session, you can turn off your camera, remove your name, change your name, or exit the recording altogether. Of course, we don't want you to do that. We think that this is going to be a very informative session. And so, Nasha, I will turn it over to you and let you kick us off.
Hi, everybody. Thank you so much. And Brian, I appreciate you starting out saying that I might be a little different than what you're accustomed to hearing, but I also want to say that I completely geek out in the proteomics space and proteomics space, that whole bit. So I will actually touch a little bit on some testing today because that's actually very near and dear to my heart and my methodology. And just to clarify, my whole family even gets this wrong, so it's not a bad thing, but it's Nasha. Think echinacea, nation, Ignatia. I'm used to it. 98% of the population. And just to clarify, I will hit in September 2024, will be 33 years out from my terminal diagnosis. And when Brian, you alluded to that I've been cancer-free ever since, that's actually not true. I've been on a journey with this. In fact, probably standard of care would say I'm not cancer-free, but I've been living well with this for all these years. And so it's had moments of ebbs and flows and expressions, and it's not a linear process, as probably anybody here who's been on the journey can tell you. But as someone who's learned how to live well with cancer, thrive, in fact, I'm in better health now at 52 than I definitely was at 19, definitely through my 20s, 30s, and 40s. So each decade, I kind of feel like Benjamin Button. So we'll just go with that, and I'll just jump into a few slides to give you a little context here. So thank you, everybody, for being here. I think this is just a share screen option. Let me actually change one thing before I do that. Sorry, guys, I should have had this more in queue. All right, let's try that again. All righty. And oops, where'd you go? There you go. Okay, let me know if this is okay. You're able to see this?
Yes.
All right. I'm going to leave my note section up just so I can stay on point, because I want to make this fast so we have plenty of time for discussion. And you're welcome you can see my brain, my thought process too, as I'm sharing these things here. But this is really about the terrain, not just the tumor. And one of the things that you might, if you've ever heard me present anywhere or hear me talk about this with my patients, I have a really big pet peeve, and I hope that in my lifetime this changes, which is the concept of a tumor board. That really is a strange dynamic to me, because this is so much more than a tumor. It's a tumor that's arising from something much greater. And so whatever we end up calling it in the future, I personally call it a terrain board when we get together in the environment that I work in to discuss what's going on with the patient. I want to know a lot more than just what's happening in their tumor. I want to know what that tumor landed in. So we're going to talk today about the terrain and the whole person in cancer care in general. And so that is where we start. The terrain tells the story, and a methodology that I've created over my 32 years, as my patients say, of going to SYA University, Save Your Ass University. I have several doctorates in that, I believe, at this time in my life. But I've learned a lot about listening to myself evaluating, looking under every rock possible. I am a really huge proponent of testing. I've now supported directly tens of thousands of patients and indirectly hundreds of thousands of patients through the way that I train clinicians and advocates around the globe now. But it's through this methodology, test, assess, address, don't guess, that I find that my outcomes might differ than those of my colleagues, because we are following data, not dogma, and we're never guessing in this process. And so terrain itself, this might seem like a little esoteric or woo-woo concept. Some of you might have heard about Beauchamp and the constituents that were at the same time as Louis Pasteur, which was saying, hey, the terrain is where the issue is. It's not the germ attacking the body, it's the environment in which that germ lands that's the problem. And that's still as old and maybe antiquated as that thought is. We've actually had researchers over time, especially someone who I have studied her work for, my gosh, 30 some years, Dr. Mina Bissell, all about the extracellular matrix and this whole concept of basically the medium in which we are trying to grow a tumor or kill a tumor is just as integral as what it is that we're applying to the tumor. So that's just something that we start with, is just let's learn the story of the patient. And so something I've learned over my career is just that there's 10 major drivers to allowing the expression of the hallmarks of cancer to express, of giving the tumor a reason to thrive and move about the body. And so for me, even the hallmarks of cancer themselves fall short because they're not explaining why those hallmarks happened anyway, why they expressed. So I look a little bit deeper, and it seems very maybe simplistic, but it seems to hold a lot of water, that pun intended, as we're looking at a bucket of water representing our mitochondria, which are these 10 drivers, such as your epigenetics, the single nucleotide polymorphisms in which you were born. So kind of your familial blueprint. We've even had studies showing upwards of 12 generations can impact your sort of proclivities and propensities today. So that's one thing we take a look at right off with all of our clients. We take a look at their single nucleotide polymorphisms. It also helps me really understand their pharmacogenomics and helps me understand what therapeutic interventions may work well or not so well. Dietary or lifestyle interventions work well or not so well. And also shows me patterns of maybe what made them vulnerable to begin with to the cancering process. Another drop we look at is obviously metabolic. So what are we fueling those cells with? What are we putting into the mitochondria to make it do its job to create energy? Number 3 is toxins. It's no longer a matter of if we're toxic, it's how bad is it and how does it interface with our own personal blueprint. And then we look at things like the gut microbiome, which most of you are old school here. You've been at this long enough to know that this is a relatively new field, despite the fact that good old Hippocrates was saying all disease begins in the gut. And Ayurvedic doctors and Chinese medicine doctors, homeopaths, naturopaths, osteopaths, chiropractors, all along the way, a lot of the vitalistic modalities and therapies and therapists saw the gut and the microbiome being intimately connected to how we think, our immune system, all of that. And now that we've been able to put our research dollars behind this and look at it deeper, we're realizing the microbiome does in fact play a huge role in how we respond to therapies, how we prevent conditions, et cetera. And then we look at the immune system. I mean, my gosh, I think this group is probably really well aware that if you don't have a functioning immune system, cancer can take off and stay taking off. That's why we're so in the era of immune therapies today, but we might be overshooting that. We'll talk about that more in a moment. And then we look at inflammation, the big driver, especially of proliferation of cancer cells and metastasis, and then hypoxia, circulation, angiogenesis patterns within this kind of circulatory and perfusion environment. And then we look at hormone modulation. We look at stress, resilience, and circadian rhythm imbalance. And the big one that's often the most reviewed or under evaluated drop in the bucket is our mental and emotional state. And at the time of my diagnosis back in 1991, I was a pre-med biology and chemistry major. And this diagnosis turned my world inside out and upside down. And I actually, when I came back to school, switched my major to biology and psychology and a self-constructed major of psychoneuroimmunology. And so the work of Dr. Robert Ader, the works of Candace Pert, later on Bruce Lipton, and others over time really informed the way I took care of myself, as well as later applied this to my patients. So these are the big drops in our mitochondrial bucket that make those hallmarks come to life, and therefore our cancering process come to life in the future. This source here is really helpful. It actually shows you many of the day-to-day things we expose ourselves to, including over-the-counter drugs, and even things you think are pretty innocuous in their impact on our mitochondrial health, which posits that really cancer starts at the mitochondrial metabolic level, not the genetic level. So that's one of the things I look at. And then you mentioned testing. So Brian mentioned that, we talk about a lot of testing, that we can get some pretty sophisticated tests today, but it's amazing how much information we can get with some standard tests. Most of these you can get from a direct to consumer lab. You don't have to even have a physician to prescribe these types of tests. So I've even done a 90-minute course on a website called Oncology Nutrition Institute, just on the utility of a CBC. 90 minutes. Can you believe it? That somebody can talk about a complete blood count. But most of you may or may not realize that things, just on a CBC, we have a lot of prognostic indicators. So chronically low white blood cells is prognostic of all-cause mortality and of cancer, cancer progression, cancer itself. Neutrophil to lymphocyte ratio, also hugely prognostic in overall survival, despite cancer rate or not, cancer risk or not. Low hematocrit is prognostic. Elevated platelets are prognostic. These are things that we can look at way ahead of time and see smoldering embers in the basement long before the house is engulfed in flames. I look at things like what my patients have coined the trifecta, which is in combination C-reactive protein, and lactase dehydrogenase, and a sedimentation rate collectively tell me far more than what even a tumor marker or an imaging, some imaging shows. I can see things brewing long before they're big enough to capture our attention. And then looking at some of these others, these are obvious, of just kind of HPA axis, endocrine function, immune function, metabolic function, coagulation issues, hypoxia, thick, sticky blood patterns. These are what we're looking at. And we could even get even more myopic and look down using organic acids profiles to look at microbiome function, mitochondrial health, toxicant profiles, co-infection profiles. We can use buccal swabs like mitoswab to actually look at complexes of the mitochondria and see where things are flowing or shutting down. We can even look at the damage to our mitochondria through the TG or the 8-OHDG or the AMA, which is an anti-mitochondrial antibody. These are relatively inexpensive tests that you can actually see the wealth and health of your mitochondria and know if you are on the right path in changing its expression. And then, as I mentioned before, single nucleotide polymorphisms, lots of other functional testing. And all of our patients that we have, we get them through blood and tissue biopsies if possible, both if possible. Either will make us happy to get a sense of the personality of the tumor itself. But what we're looking at here on this thing in front of you is basically the health and wealth of their terrain itself. There's a hyperlink on this Terrain 10 survey. We can share these slides with you at the end, but this actually allows you or your patients to actually do a kind of a personal audit on everything you're putting in, on, and around you, and what type of pressure you may be putting on your mitochondrial health to help you determine a different path than the one you might be on currently. And so this has been, again, developed over all of my years. And one thing I want to say here on my notes is that average versus outlier. This is key. Average is what our labs are based on, the average of the population. And at this point in time, we've shown that less than 6.8% of Americans are metabolically healthy. So we don't want to be average. We want to be outliers. You want to be Brian, I can't recall exactly what you called me, but people saying I'm a hyper responder or, an outlier to the nth degree. And I look at Glenn and other people in this room and thousands of others that I've had the privilege of working with. We don't want to be average. We want to absolutely leave the building. I also want to really highlight that I feel like though we're doing a lot of amazing stuff with testing of blood and tissue assays, we're also doing it incorrectly. Most doctors are unfortunately still using the initial tumor, which is completely irrelevant data at this point. Once you have had a treated tumor, you have the potential of changing its expression. And if it's gone for more than 6 months or so, there is this possibility of the changing of expression. So fresh tissue or fresh blood are really important to move things around, especially if someone is not responding to therapy. You want to get new information on them as much as possible. And I also don't want to forget 2 major tests, which are observation, hands-on physical, nutritional examinations, deep observation, watching the patient's persona, their shen in Chinese medicine, how they look, how they present, what's their confidence, what's their anxiety, as well as your intuition. Intuition is also downplayed in medicine. This is, I can't even tell you how many times just a hunch led me to something that led to a patient having a better outcome, because it was just like, something's not right here in the data. Let's kind of tap into other channels of wisdom. And so the future of healthcare, I mean, I alluded to that I'm now part of a huge network. After having a year-long wait list in my clinical practice and leaving practice and then consulting and then getting a year-long wait list for that and leaving that, moving into training doctors and then getting a year-long wait list of doing that, I realized this one-to-one was not working. And I knew it was crushing me under the weight of it. And it was also crushing me to see how many people were literally dying in the waiting room. So to date, we started training clinicians globally and patient advocates, which are allied health professionals, folks who can't order imaging perhaps or prescribe, but they have some medical background, nurses, occupational therapists, nutritionists. So to date, we have 265 clinicians, 362 advocates in 36 countries, with 2 cohorts matriculating a year, and each cohort tends to have more and more people. And just to give you an example of who's looking for this type of care, in January alone, we had 35,000 people come to our directory looking for someone to help them using this approach. We can't meet those numbers and we need more help to meet those numbers. But that is the future of healthcare. It is now. And so this metabolic approach is about using the right tool at the right dose, time, and duration to keep the patient on the path to healing. And this use of frequent testing, enabling regular reassessment and guidance and adjustment to what's going on. And then just to reiterate what current standard of care cancer treatment is, are a lot of amazing things happening now. There's a lot happening in immunotherapies and targeted therapies, stem cell therapies, dendritic vaccines, et cetera. There's quite a lot happening, and we can get excited that we're making some movement and maybe stepping a little further away from good old, radiation and chemotherapy. But there's also, maybe someone go and mute there. There we go. And so the integrative oncology, the Society of Integrative Oncology, has added to that. So standard of care, in addition to what I call the low-hanging fruit, and I don't mean this in any disrespect, it's just, I personally think that everyone should be worrying about meditation, acupuncture, nutrition, dietary, massage, lifestyle modifications, yoga, exercise. We'd all be served with that, not just the cancer community. I don't consider this alternative or integrative. I just think it's part of living on planet Earth today. But what I am interested in is what I currently do, what I currently train clinicians in, and what I hope the future of oncology makes as standard of care is how do we improve upon what standard of care in SIO, Society of Integrative Oncology, considers cancer care, which is properly evaluating for and preparing a body for surgery, or properly evaluating for and preparing a body for chemotherapy, and making sure we know exactly what we're targeting. And we can use metronomic, less toxic, and chronobiologic approaches. So improving upon standard of care, using fractionated radiation in partnership with things like hyperbaric oxygen or hyperthermia to change the perfusion of the healthy tissue and hone and sort of target the cancer cells even more readily. And then looking at some of these other therapeutic interventions, which we're going to just touch on here and then open it up for questions and commentary, but using IV therapies to enhance standard of care. We should not have to be making a choice as patients as to whether we're getting standard of care or alternative or integrative. This should be standard of care. We have enough information now to know that my job as an integrative doctor, I help standard of care oncologists do their jobs better. It's not an antagonistic process. There is not a chasm between us. There is a bridge and a partnership to be had. And so things like using fever induction therapy is we were laughed at using Coley's and mistletoe for all these years. And now we put the majority of our research dollars on these types of immune therapies. We were laughed at the idea that using something like hyperbaric oxygen could be negating the impact of standard of care. And yet we know that it sensitizes cancer cells to radiation therapy. So wouldn't it be amazing if our patients could hop into a hyperbaric chamber right before they go and have their radiation? My patients do, which is pretty incredible. And then therapies that have actually been approved for cancer care since the 1960s, sonodynamic, photodynamic, photobiomodulation. Many of you have probably heard of the Edison histotripsy, which is basically like lithotripsy on your cancer cells. These are therapies that are absolutely approved, and yet why aren't we using them? Why aren't they part of your approach? Because they're already approved for things like esophageal cancer, head and neck cancer, superficial cancers, and do beautifully. And then when you take them more intratumorally and intravascularly, you can even enhance standard of care and other therapies even further. And so one last piece here, I know a lot of you have heard Dr. Gatenby speak here about the adaptive approach. This morning I had a meeting with somebody from Moffitt, previously with Moffitt Center, but this is the place that I still don't understand why we continue to beat to the drum of the maximum tolerated dose approach. This is that approach of basically taking your patient to the brink of death and hoping there's enough to work with to get them, to stay alive or to deal with survivorship once this is done. I really love this emerging theory, this adaptive approach, and it's how I've approached it for myself and my patients over decades. And I love seeing that there's more and more research around this. And so I think that this is also what the future of cancer care has to offer, is moving more to this adaptive versus maximum tolerated approach. And then just an example, I wanted to give you a brief example of how I help the doctors know when to push and when to pull back. It's not just, a protocol. I am really against protocol medicine. I really want to evaluate each individual personally and know exactly what it is that they need. And so what happens is a patient maybe goes to an integrated provider and they get everything, including the kitchen sink, thrown at it. That's just as damaging as just maximum tolerated dose chemotherapy that hasn't been given more thought. And so I really want to bring up the best practices of all. I want all of us to rise together of how we could do this better. And so this is just an example of how I can know when a patient is too oxidative, too overwhelmed in their system, to know that you don't want to add more insult to injury. That's not the time. This is the time to back off and do more adaptive approaches versus maximum tolerated dose approaches. So we help the patient, we help the clinician determine whether or not they can push that patient that day, or if they need to take a different approach. And so using labs, even using in-house scratch tests, urine tests, pH papers, just to understand how dysaerobic or anaerobic they are, then lets us know, hey, if they're more in the anaerobic state, we can push hard. We can hit them harder with these oxidative therapies. But if they've moved into a dysaerobic, which is unfortunately the vast majority of patients who come to somebody like me or one of the colleagues that I train, we often push our patients right off the cliff because we tend to still be pushing very hard in the anaerobic category. But if we actually pull back and focus this more in a dysaerobic, these patients have unbelievably different outcomes than those patients who hit it hard with everything they've got. And if a doctor is confused and they aren't quite sure where the patient lies, or the patient's bouncing wildly between the two, we kind of go into the Switzerland zone, this neutral approach. And these are just examples. This is just kind of one case example I was kind of thinking about to show you this diagram to help you understand that there's a nuanced way to go about this. And finally, just some of the therapies that I think are very, very promising with regards to metabolic therapies that both enhance a lot of other integrative therapies as well as standard of care therapies, various forms of fasting, therapeutic ketosis, restricted window eating, fasting mimicking diets, the use of oxygen therapies, the use of glutamine blockades, off-label drugs in a variety of forms, certain supplements that also change the metabolic pathways. As I mentioned before, photodynamic, mistletoe, high-dose vitamin C, hyperthermia, deuterium depletion, molecular hydrogen water. All of these have been shown to be very, very metabolic centric in the way they treat the cancer. So I think that takes me down here to just, the train is just where cancer takes root. And we need to be mindful of that and helping elucidate what that pattern was so that we don't continue to return to that again and again. It's truly impossible to heal from the soil in which you got sick. And my job is to help patients and clinicians understand what that why was. So we know where we are, so we know where we need to go. And finally, just a couple of the books I've written goes into a little deeper dive of this, as well as ways to learn more and ask questions. So I'll leave it up to you here. Thanks.
Great. So thank you, Nasha. That was really a fascinating intro. And so Eric or Chad, do you want to kind of kick us off here, given some of the experiences that you've had?
Yeah, sure. So Nasha, while I have not specifically studied your work and your content, ironically, I've done probably about half of those things that you mentioned on the various slides.
Awesome.
Through some of our own research, as well as going to a naturopath that follows many of those things, right? Hyperbaric, mistletoe, IV supplements, high dose vitamin C, on and on. And I feel that this has really been a big piece of my journey to one, help my cancer progression results, as well as just help me feel better, kind of counteract the toxic effects of kind of the conventional medicine treatments. So I guess that's kind of a quick summary of my experience. I don't want to take up all the time here with this group talking about mine. We can do that some other day. But I really appreciate this topic because I'm a huge believer in this. This is a large part of my journey.
Thank you, Eric. I appreciate hearing that. Thank you.
Yeah.
Thanks, Eric. Use your raise the hand feature in Zoom if you have questions. There are some that are kind of like coming through in the chat, so I'll try to bring some of those forward, but I do have one that's kind of like top of mind. I was recently listening to Paul Stamets talk about the effects of turkey tail and was it Adirondack?
Adirondack,
yeah. And just the synergistic effects it has with helping to create reduce inflammation and improve your immune system. And I'm just curious, he just recently gave a talk about this at Georgetown University. I'm just curious to get your thoughts on it. I'm at UC San Diego primarily, and there's a Dr. Sachs who is there, and I just started looking him up yesterday. So this is all fresh information, but I'm just very curious to get your thoughts on that particular cocktail of mushrooms and what effect it could potentially have.
Well, first of all, I mean, I love that you brought up Paul Stamets. I tell people, if you want to understand how my mind works, read the book Mycelium Running.
Yeah.
And so that is, that's just kind of the way I see. It's hard to unsee that for me, seeing the terrain and that soil concept. I saw that Brad was asking that question, kind of the synonymous tumor microenvironment, extracellular matrix. There's a lot of different names for it. I just think of it as terrain. But where the mushrooms are, it's very interesting. They have a very, very powerful role. But I will tell you something, this often surprises folks. I learned this both from my Chinese medicine training, but I also learned this later in my immunology training. Mushrooms strongly promote TH1. And so with that, that's great in the cancer place. But if you've got a patient who also has autoimmunity or who is taking, say, an immune checkpoint inhibitor, these don't really have a good, they can kind of get you in trouble. So again, this is where we have to look at the N of 1 of the individual. So I evaluate I can do testing like through Cyrex Labs and do a full lymphocyte map test and know exactly what presentations someone's immune system is up to. So I know if I can push that immune system a little bit towards a TH1 or not. I can look at things like just their medical history. Do they have a history of autoimmunity? Are they currently having an autoimmune flare? If they are, I'm not going to be one to reach towards those mushrooms. But if they don't have those issues, man almighty, you can watch the natural killer cells go up. You can watch the Th1 shift happen. You can even watch the macrophage shift happen pretty quickly with that. So it's not even a guessing game. You can see that happen on just watching what your monocytes and your eosinophils and your sedimentation rate are doing on your blood testing to know if they're helping you or pushing you off a cliff any further.
Interesting. Okay,
Yeah.
great. I'm going to let some others chime in. I do have another
Thank
question,
you.
but I see that Brad has his hand up.
Thank you. Nasha, now I'll pronounce it correctly.
It's all right.
I put a question in the chat, which basically, we know that the disease is complicated. When we've had people on like Dr. Gattenby, and you try and model a disease, it makes your head explode just trying to think of model it. But then to say, okay, I'm going to get a genomic analysis, and there's a simple, you might call it cookbook medicine. If you have this ALK positive, then we've got a drug for you, and this is the drug. So that's targeted therapies, but it's very mechanical. It's very simple. It's very reductionist. And as I look at what you're laying out, it kind of, again, it blows my mind in a different way, because the menu of treatment options just exploded exponentially. And then if you add combinations on top of that, it's like it blows up even more. How do you, and from our conversation last week with Babsha, we kind of got the thing, it's not like hyperbaric oxygen and that's a panacea and everybody should get hyperbaric oxygen. No, it's like if you are in this situation and you're combining it with something else. So now the menu gets really complicated. So how do you make sense of it when you're working with a patient? Maybe you can put it in an example where, for example, I'm getting a cancer vaccine, and just to drop something else, I reached out to Gabrielle Gavazzi and Mark Taylor, and I said, if you want to maximize the impact of your cancer vaccine, you're taking immunotherapy, then what would you do? And then, I got a list of 8 different things. Is that how you think about it? So it's just, making sense of a very complex disease and treatment menu. How do you organize?
Well, great question. Number one. Number two, I'm really glad you connected with Mark. I'm assuming you're at the Valencia clinic. And since you're heading down to Morocco, you're staying close to each other. No? Okay.
No, that's coincidental.
Okay, perfect. So with that though, so again, I've been at this for 30 some years for myself, and my brain is a systems thinking brain. It doesn't see things very linearly. And so my brain sees, those pictures you look at that have the squiggly lines, and if you kind of cross your eyes or relax your eyes just enough, suddenly you see like a dolphin jump out at you. That's my brain. And so it's not everybody's brain. And so I've been trying to teach that to others. But what we've done instead of, because I can look at the whole field, if you will. I can look at their labs. I can look at their family of origin story. I can look at their biography as well as their biology. I can look at their tissue assays, their tumor markers. I can look at their SNPs. I can see it all at once, and a picture reveals itself very clearly of what their patterns are and what their treatment of choice should be. Not everybody can do that. And so I've been training in that. And as such, we've been building a data platform. Because taking in all those metrics, taking in that vast amount of information, that test and assess is what then elucidates the patterns, which then elucidates what is the right therapy at the right time, dose, duration, and combination. Because you can have all these amazing therapies on, but if you're not doing them in the right order or the right stacking, it's futile. Nothing good happens of it. And so this data platform we're building is creating the rules-based engine and the AI to help doctors create a clinical have a clinical decision-making tool at their fingertips. So those who don't have a brain like mine can have a little bit of a training wheels to get them there quicker and to kind of start to gather this information. So we are hopeful. We're actually looking for the next phase of our funding to get the next part of our AI developed. We've already been using this data platform in our environment, in our beta on all those clinicians I've talked about. So we've already gotten to see it in real time, and it takes about a 6 to 7 hour prep for a patient down to a couple of hours. And we hope by the time it gets to market, it'll take a prep for a patient down to about a half an hour. And then you can really know what works, when, why, what, and where to use. So to your point of that algorithmic recipe book, that is also happening. And it's also no different than the experiment we've been on for the past 70 years, which is here's a target, here's a treatment, here you go. And when that fails, you move to the next target and treatment. We might be doing it with off-label drugs or with certain nutraceuticals or herbs, but we're still applying it in the same antiquated way. And so we have to look deeper. So for instance, radiation. If your insulin is high, radiation is not going to work well for you. Your cancer cells are desensitized. So you can use things like hyperbaric or like being in a state of therapeutic ketosis to enhance the response, to sensitize those cancer cells. With regards to the immune drug you just described, I look at, it's funny, in 2018, MD Anderson put out a prognostic score questionnaire, 7 questions. That's all they asked. Are you over the age of 52? Is your ECOG score more than 0? Do you have an elevated LDH? Do you have an elevated platelet? Do you have an elevated neutrophil? Do you have a low lymphocyte? Do you have anything going on with your liver? If you answered 3 or more on those having issues, you are not a good candidate for an immune therapy drug, because that already shows you're in a Th1 dominant state. It already shows that there may be an immune system completely off the grid. So you need a somewhat of an intact immune system to respond to an immune therapy. And so before you even consider jumping on an immune therapy, I would really look, Brad, to see how you score on that MD Anderson score. I would look to see what your autoimmune history is. I would look to see in the German medicine, we'd look at your anamnestic score, which are very similar questions to what the MD Anderson's looking at. If you have either a heightened immune reaction or a completely off the grid immune reaction, you'll have very little response, if any, or even a really bad or negative response to these. And so that doesn't mean that they're off the grid for you forever, but you'd want to work to getting your terrain ready to meet that treatment. So I see this a lot where people rush off to get their T-cell dendritic vaccine, or to go off and get their Coley's toxin, to go off and get their checkpoint inhibitor, or go off and get their injection of interleukin-2 into their tumor or whatever. And when it blows up in their face, everyone's confused and surprised, and we could have seen it coming a mile away. So those are examples that the technologies we hope are coming to help make this automated for most clinicians, and to teach them to be critical thinkers again, and to do it in a scalable, repeatable way. Did that answer your question?
Very much. Thank you very much. I guess the one wrinkle would be combinations.
Yeah.
Because I think we would generally, and we've done work with Cure Match, you may know them, and
Yeah.
they're advocates for combinations. And so, you know, how these things interact is yet another complicating factor.
But there's so many things, like you just kind of come back to the basics of their mechanism of action and knowing what's going to enhance or potentiate. So for me, there's certain stacks that are kind of a given all the time. If I'm going to use any immune therapy, I'm always going to want to partner it with hyperthermia. Those are just examples. Like that just is a potentiator. If I'm going to use radiation, I'm going to always potentiate it with ketone bodies, whether exogenous or endogenous, and hyperbaric oxygen and high dose melatonin, for instance. Like those are just some examples that come to mind of where I know they're kind of the low-hanging fruit stacks. And then the nuances come from the information, the data that the patient's body gives us.
I'll be going to the sauna and the
actually perfect.
The ocean in Maine now that I know. Okay.
I love it. I love it, Brad. Thank you. Great questions. Chat.
Someone at chat. There you
go. Presenting a really great topic here. Many of us highly treated, so we have possibly, or you talked about neutrophil to lymphocyte ratio maybe off, or might have some reds or white cells that are low, or hemoglobin or something. Is there some complementary treatments when we're on a break that we could maybe help us out getting those labs looking better to keep us qualified for treatment?
Absolutely. I love that question. And Chad, if it's specific for you, I'm happy to answer that offline. So make sure to reach out to me there, Nasha at mtih.org. But there's again, it depends on, okay, if it's just chronically low white blood cells, well, we can use, there's actually a really beautiful, sustainably, ethically harvested shark liver oil. Alkylglycerols work just as well, if not better, than the Neupogens and Neulastins without firing up the oxidative stress to the marrow and to the system. That's one example. There's a ton of others with regards like chronically low, like anemias and whatnot, secondary to treatment, hyperbaric oxygen. You'd be shocked, not a high pressure, a high, time frame, but like a little bit will just kind of potentiate and support. But there's a lot of tools in the toolbox for that, both from Chinese herbs. There's a ton of support, nutraceuticals, certain nutrients, platelets that are chronically low, things like papaya leaf extract. It just shocks people how well that, even tahini, can work on bringing the platelets up very quickly. We're talking days or weeks, not months. So there are a lot of great tools on that, Chad. I'm glad you brought that question up. Yeah. And many are safe to even do during treatment, not just having to wait when you're on the pause.
Great, thanks.
Thank you.
Jeff.
Hey, everybody. So I have a question. I do work with an integrative oncologist, an MD, and many of these things have been periodically part of my treatment. But I had a specific question. In the course of treatment, I was getting periodic, very comprehensive, immune system blood work, including an NK cell activity test through Quest, and Quest stopped offering those. And that was a very good tool for me because I could see not just ratios of different lymphocytes, but I could also see, based on their standard tests, which was a kind of a lyse of some particular bacteria and account, how my immune system was actually doing in terms of activity. So I'm wondering if you could say a little bit about that, and if you know where that testing can happen. The only thing I've been able to find is one or two hospitals that offer it. It's not covered by insurance. It used to be when it was at Quest.
Yeah. Well, first of all, it makes me sad that you're right. They kind of keep chipping away at the things that we used to be able to get coverage for insurance. So I was really grateful a couple of years ago. It's not cheap, but it's effective, especially if someone's dealing with some immune issues or looking at immune therapies or really trying to monitor how their immune system is doing. It's worth, to me, the $220 it costs to go through Cyrex Labs. Dr. Vojdani, Dr. Vojdani is a really world-renowned immunologist as well, and he has a lab called Cyrex Labs, and he introduced just a couple of years ago what's called his lymphocyte mapping test. And this will show, Jeff, not just your natural killer cells, it's going to show interleukins, it's going to show TNF alphas, it's going to show your T cells, it's going to T cell dendritic T cells, it's going to show relationships of Th1 to Th2. It is incredible. It shows you 13 different patterns of immune expression, and what you might have one, or you might have half a dozen of those patterns expressing, and you can really watch it and monitor it. And once I find a patient's pattern, then I can usually go back to ARUP and repeat with just some of the specifics, because you can one-off order a few of these things still and have those covered. So if I see a particular pattern, then I can then go back and we can follow and monitor it with insurance reimbursement for some of these other tests. So that one might be one to go take a look at.
Okay, thank you.
Yeah, absolutely.
Carla.
Hey, Nasha, thank you so much. This is super helpful. I'm just curious for, patients that are interested in, and I see actually you've answered this in the chat, but just gaining practical access to some of these therapies. I think, certainly what I've found, and, maybe others have had similar experiences, just, it's difficult to really, integrate tightly some of the, more kind of alternative or, other supportive therapies with kind of, standard of care protocols. But sounds like a good place to start is really finding, some of these integrative oncologists.
Yeah. And specifically who've been trained, because I will tell you, I feel like the majority of my training now are to doctors who've actually been integrative oncology specialists for some time, who are, I don't mean this to be harsh, if any of you are in here that are listening or are this type of oncologist or integrative oncologist or integrative practitioner, protocols, you guys, don't work. They might work for a hot second, but they don't. You have to be trained in how to know what, because this, even Amit was just asking about, well, when do you know something's working or not working, especially when there's so many things thrown at it? You don't. That's why you take this method. That's why you do very focused testing and evaluation, and you repeat it. So we look at our patients' labs every single month, and then we regroup. Plus, we check in periodically within that. If something starts to change before that next monthly lab is set, we're going to test sooner than that. And so this is how we adjust course and then know what therapies are working when and where. So you want to work with someone who's doing an enormous amount of evaluation on you before they start to say, oh, you have breast cancer, we're going to do this. Oh, you have this, you're going to do this. As soon as someone says that, that's a red flag for me, and I run, or I encourage patients to run. Because you could put 10 patients with breast cancer in the room. They could have the same demographic. Maybe they're 30-year-old triple negative breast cancer patients. You evaluate their data, and they all have cancer for very different reasons. They'll even have very different tumor personalities, as well as terrain situations that led to that diagnosis. So we need to have a very focused approach to this to have success. And it's tedious, but it's required to save your life, especially for someone who's got a later stage cancer. The earlier stage cancers, protocol it, right? If you want to go that route and that feels comfortable in a stage 1 or 2, but man, once you move into being highly overly treated, non-responsive to therapies, or really coming in de novo with a aggressive cancer, you got to be a lot more thoughtful and precise about the path you take forward from the get-go. Don't guess in that space. You have very precious, limited time and resources to get it right.
Great advice.
Thank you.
Bapcha, Eric, I see your hand up. I'll come back to you.
You want me to talk, or?
Yes,
Yeah.
yes.
Oh, all right. Hi, Nasha.
Hi, Bapcha. Good to see you.
Nice to see you. I'm on 2 screens because I couldn't put my hand up on my laptop, but I did on my
Okay.
phone.
All right.
So anyway, how are you doing today? Thanks for the
Excellent. Thank you.
presentation.
Thank you.
Your last sentence was about hydrogen water. Can you talk a little bit more about it, please?
Sure. So I used to think this was kind of bunk. I'll just be really honest. I'm usually that person who's like, let me see the data and let me experience it. I'm usually putting it through my own body first to see the outcomes. But I was really shocked when I started hearing and seeing why I started really getting into hydrogen water this last 2 years. And I think I can say this in this room. I started getting really tired of my patients with cancer who'd either had the COVID infection or the COVID injection, dealing with extreme coagulopathies that were not responsive to the typical therapies I saw them respond to historically. I used to be able to take a fibrinogen activity level from 450 to down below 300 in a matter of weeks with lumbrokinase or seropeptidase or, natto or something. These stopped responding. I used to be able to use heparin if everything else failed, or other pharmaceutical blood thinners. Nothing was responding. And I heard a story about a colleague who had long hauler COVID, who was dealing with really, really bad clotting issues, very, very elevated platelets, very elevated D-dimer, very elevated fibrinogen activity. And he started nebulizing molecular hydrogen. And I thought, well, let's just see what his data shows. In 2 weeks, he dropped his fibrinogen activity more than 50% from well over 900 to below 350. He dropped his D-dimer into normal range, and he dropped his platelets from over 600 down into the high 300s in 2 weeks on this. And I thought, okay, now I got to get curious. So I dug a little bit deeper and started to realize its impact. It is a very well-documented metabolic therapy. It is directly impacting the mitochondria. It is directly lowering inflammation, specifically interleukin 6, interleukin 8. We could see that. We started testing. It definitively drops fibrinogen activity, platelets, and D-dimer. Interestingly enough, in patients with low platelet counts, with high fibrinogen, it does not lower their platelets further. In fact, it normalizes it, which was an accidental finding. I have no idea the mechanism of that, but we've been watching that. And so it's something that we've been bringing into our patients with really tenacious fibrinogen pathways. So that's what I know. We actually have I've got 2 recordings coming out on my podcast and one on a cancer summit coming out with 2 experts in this field. And so Bapcha, if you stay in touch with me, I'll give you their names and you can follow with their research to get more of the details, because I'm relatively new to this.
Okay, so my basic question goes back to physics.
Cool.
It is very hard to enrich water with hydrogen.
Yeah. Yeah.
It can dissolve only so much. The rest of
Exactly.
it is bound to oxygen as H2O. So
Exactly.
I'm assuming you're talking about the free hydrogen in water, correct or not?
Well, both of these gentlemen have technologies that have managed to overcome that barrier.
You cannot overcome physics.
Okay, cool.
Okay.
I would love,
You
well, I
cannot.
would love for you to talk to these guys because I am not a physicist. So talk
Okay,
to them.
thank you.
I'm also, but I'm
you
also
can-
just intrigued at what I was seeing because, like, I was like
Right.
you, I thought bunk, but when I saw
but-
the results I was seeing, I was like, okay, I got to look a little deeper. So we started having several patients bring that on. So I'm with you. I'm learning. I'm asking those hard questions too.
Fair enough. Sounds good. And were they done with any controls or not?
With the patients I used it on, we were just using it because we exhausted everything else.
Okay.
And so, but this is actually one of the things I'm discussing with one of the companies with one of their technologies to do some actual research. So that's our next step. We're looking into that next step.
And how do they claim to enrich water with hydrogen?
I'm not a physicist. I'm not at that piece, but it's a particular technology that they go into in the podcast. I'll send you their links and their names because this is really not my area of expertise.
No worries. That was the last sentence in your entire
Great.
presentation. So
Yes.
I sort of hung on to that. So thank you so much for your responses. Yeah,
Absolutely.
let's keep in touch by email.
I would love
or
that.
something.
Thank you, Baksha.
Thanks.
Thank you.
Thanks.
Thank you, Baksha. Amit.
Hi. I guess you answered part of the question in the chat, but can you guys hear me? Okay.
Yeah, a little bit of an echo, but we can hear you.
So, I'm a highly treated prostate cancer patient. I've tried a lot of integrative therapies from, juicing, intermittent fasting, millet-based diets, Ayurvedic treatments, worked with Mark Taylor also, worked with Dr. Donald Abrams at UCSF Osher Center. And at least I cannot tell that any of those things have meaningfully helped me manage my disease.
Okay.
I think it probably has helped in a little bit, in very incremental, as small as steps that I could tolerate some of the other treatments well. But the more I kept looking into this thing, for every therapy that gets suggested, there are 8, counter arguments against those. And I've just not found that there's a stable operating point from any of these things that I can rely on and say that, okay, if I am consistent with this is something that is going to help me. I went through 2 sets of immunotherapy treatments and, consulting Dr. Sumit Subodhi at MD Anderson for immunotherapy as well. And again, the counter indicators he gave me against immunotherapy in my case, and especially a lot of the supplements, I came out with this, I did this recently, I did this Dr. Onyx treatment on immunotherapy, and they gave me a 3-page protocol called Blaylock, Dr. Blaylock protocol. I mean, that is just it was totally counter to everything else that I was kind of doing or I was being given previously by Dr. Abrams and other doctors. So I found it almost impossible to figure out what is going to work or what is not going to work. I haven't done the terrain mapping, and I get CBC and all those things done almost weekly, actually. So monthly testing is not an issue, but nothing that has really helped me unravel the mysteries of this and say that, okay, if I'm consistently following this, because what has happened is typically for I've followed something for 4 to 6 months, and then kind of something counter indicator has come up, or some side effects have popped up, and we don't know whether side effect is because of what. And then my onco team says, well, let's just stop this and see where we go. So anyways, I wanted to see your response to that, that this is a very, very confusing landscape that nobody seems to be able to kind of unpack in a meaningful manner that you can trust and work with, at least in my case.
Well, and I mean, question for you. I mean, you talked about some of the testing, but I'm curious if you'd had all the testing done that I showed you on that screen of kind of that's our onboarding tests, and then we will repeat those tests quarterly as needed. But also, what happens when I have a patient who's been heavily treated and they've stopped responding as robustly as we'd like, we'll take a pause from whatever treatment you're on for 2 weeks. And then we'll go back in and do, if you've got something biopsiable, we'll go back in and get a fresh tissue biopsy, or not biopsiable, go and get a fresh blood biopsy and see if there's some new targets that have arose, have risen, because that will happen, especially in a heavily pretreated environment. And so just curious if you've done that approach. And then the other side is, prostate cancer itself has a little bit of a different metabolic expression than other cancer types. And I find that there's a lot of confusion and miscommunication as to how to eat, what to eat, when to eat with this. And it's just looking at your single nucleotide polymorphisms help, looking at your terrain labs help. But it helps us determine, like, you are probably someone who needs to be both carbohydrate restricting as well as being careful with the types of fats you take on and how often you take those on. Choline can be an issue in this process. So I just mentioned that. And then someone had asked me in the chat about ferroptosis. This is a cancer type, especially if you have SNPs in or elevated on your labs, interleukin-6, and a chronically elevated ferritin level. Ferroptosis can be one of the most profound ways that I've had patients resensitized to whatever standard of care therapies they were on, dealing with late stage recalcitrant prostate cancer, that I think that would be worth looking into. But again, I know, like, knowing you kind of named off a few people that are really highly regarded in the field of integrative oncology, but I also find that none of them quite test to the level, frankly, of my standards. And I think that we can often find clues as to what they might be missing with you, Amit. And then I can't underscore enough in men in general, and this may be very personal, but this is more general here, that men in general, like the prostate, like, that is the bowl of, like, where you hold all of your stuff, your emotions, your stressors, all of these pieces. So making sure you're attending to that part of your terrain as well, because it can sort of perpetuate this even further. So I plant those seeds to hopefully know that you've not likely exhausted all of your options, Amit, and that this is hopefully encouraging you to work with someone who can look under the hood with you a little bit further.
Yeah, I haven't done all the testing that kind of, the long list that you've shared with me. But at the end of the day, what is the goal that you are trying to get your patients to? I mean, what is achievable? Let's not talk about extreme responders.
Yeah.
We know there are exceptional responders to everything.
Right.
But on an average, what is it that you are able to get your patients to with these therapies?
Well, I think it's interesting. My colleagues for years, when I was in private practice still, they would say to me, why do you have such good compliance? Why do your patients do everything you tell them to do and stick around? And it's because I educate the crap out of them. I empower my patients. So they understand exactly why we're ordering whatever we're ordering and why we're offering or giving whatever treatment we're giving. They become just as savvy and sophisticated in their own process than their doctors in most cases. This is why I had to go back. When I first started consulting, I was just consulting with patients, and I realized, and this is by no means, I'm not trying to be disrespectful, it's just the reality of the time. Back in 2015, the patients were smarter than the doctors. So then I had to go back to the drawing board and start training doctors, because the patients were bypassing them quickly. And so now we train both simultaneously. We train advocates and patients and clinicians at the same time, so that everybody can be at the table together. But when you ask about that question, we're very careful to not to talk about this. This is why we're building this data platform, and this is why we're building this network and collecting these stories so we can publish. Because at the end of the day, here's what I know is that when you take all stage 4 cancers and you put them into a bucket, at the end of 5 years, the average is 12% of those are still here. Okay, so every tumor type, we're not like breaking this down into types. So like on average, about 12% are still here. At 5-year mark, in my patient population, over 60% are still here. We're doing something different. We're doing something right. We're very careful about how we talk about that, but we are very careful about testing each person and applying all of this very individually. And so we aren't for everybody. This is asking a lot of the patient and their caregivers and their loved ones. This is a commitment to a lot more than just come in, have a treatment, walk out the door. This is a lifestyle. And this is a state of mind. And so my hope is that most people, we require them to read Metabolic Approach to Cancer first and be like, does this resonate with you? If it does, great, let's have the next conversation. If it doesn't, then best to you. There's plenty of people out there doing protocols. And when those fail you, then they usually come back to us, which sucks because by then it's really late. Right. So I wish that we got everybody started on understanding their terrain, evaluating their own terrain, taking their own terrain 10, taking their own health in their hands and becoming an empowered, educated advocate for themselves so that they're more inclined to do all the things. And also one other piece here is when a patient is in chronic stress or duress, no treatment, no matter how good it is, will work, right? Or work for long. So we have to even change the field in which that treatment's being received in. And so these are the esoteric things that standard of care isn't designed to help, but this is exactly where the world I work in, I think, shines. And so we bring this all together to bring the patient into the center of the equation.
Great. I want to be
Thank you.
mindful of time. Nasha, we're 3 minutes after the hour. We have Eric has a question. I had also another question.
I've got a few. I've got about 15 minutes, so I can go till quarter after. Yeah.
Awesome. Thanks, Eric.
Okay.
My question is maybe perfect timing based on your last comment.
Okay.
So I was going to go back to the beginning when you mentioned, according to standard of care, you are probably not considered cancer-free. And so I guess I was wanting to talk more about that mind shift, but between that, the standard of care approach of eliminating all cancer to be, quote, cancer-free versus what I think I hear you talking about is kind of more of like it's a lifestyle change, like you said, and I've done a lot of that myself, but kind of like a maintenance or a way to manage it at a certain level. And so I guess I was hoping you could just expand more on kind of that mind shift part of it, because it's very different if you've only been in that standard of care world, right? I have not, but I know a lot of the other audience here has. So I think that's a fundamental concept when we talk about all this stuff that you've presented today.
That's a big one. And so I appreciate that you brought that kind of back up, because I think it underscores, I think, why I'm still here is sort of a little more context to my own diagnosis and what put me on this journey is up until I was diagnosed, I'd had a lot of health issues. I was literally born with health issues. By the time I was 3 years old, I was on multiple drugs for IBS, so like baby Prilosec and those things back in the early 70s, what was available at that time. I was put on birth control pills at 9 because I started menstruating, not normal nor common, unfortunately more common now, still not normal. But in 1979, that was a really big concern. It wasn't until then in 2011, I was diagnosed with endometriosis, or 2011, when I was 11, endometriosis, then polycystic ovarian syndrome. From the multiple antibiotics and whatnot I was put on, I was diagnosed with juvenile rheumatoid arthritis, later Hashimoto's thyroiditis, later full-on IBS. All of these pieces just kept stacking. So by the time I was actually diagnosed, 6 months prior to me being diagnosed, I was in and out of the ER, and they just thought it was more of my symptoms being exacerbated, right? They just thought it was more of the same. I was a zebra. Back in 1991, you weren't looking for a 19-year-old with terminal ovarian cancer. It just wasn't what we were looking for. And so I also will tell you this part of my story, which is not often for public consumption, but I have shared it, is I tried taking my life on multiple occasions. Came from extreme trauma, extreme abuse, extreme poverty, no way out, no light at the end of the tunnel. There was nothing. So it was easier to leave. In fact, my first moment I had the diagnosis, there was relief. I was like, well, that's kind of a martyred way to go. Great. But then something else happened in me. It was sort of like, here's an opportunity. And so when there was told there was no way, I didn't expect to fight it, didn't expect to cure it. Instead, I expected to just understand it. That was where that's how my mind shifted, was in understanding of it. And as such, from things like having a bowel blockage, accidentally not eating for 2.5 months because I couldn't, that probably saved my life. Now that we can look back on the impact of like Moreshi's work from 1909 on fasting and tumor debulking, that's what opened up my ureters to start working again. That's what helped me start to resolve the ascites that I had to continuously drain. That's what took the bowel blockage away. So these accidental kicking the can down the road things are what led me to getting more and more curious as to these other pieces. But what I really found for me was the mindset. And because I was not afraid to die, because I tried to take my own life, I learned pretty quickly that was actually probably one of my superpowers. And when I got into private practice of helping patients, that was the biggest hurdle we had to overcome, was their fear of death. And from my perspective, from my opinion, patients who are so focused on fear of dying, they literally forget how to live. And so my job is to help them start to remember how to live. And when that mind shift happens, you will see a lot of metrics change with that. And if I can't bring it to them, we now have lots of tools that we bring to them, everything from EMDR and other, Liberate is a new platform that's out there that's a precision emotional healing tool, and a lot of these other things, but even psychedelics. And I'm often not very much to speak on that, but psychedelics were probably integral to my trauma release in my early years of overcoming this, back way before Michael Pollan made it okay to come out of the closet, way before these studies. I had 11 patients who went through the Harvard trials for ovarian cancer, terminal diagnosis, that all but one of them are still here. And that was in 2010 and 11. And so like these stories, people were asking in the chat, like, wow, when do you talk about, like, I see these amazing responders every day, every single day. It's so weird to me to go to an ASCO conference and hear them say, how many of you have stage 4 cancer patients that have made it, and be in a room where virtually no hand goes up. I'm like, I don't even want to raise my hand for fear that I'm going to be attacked. And that's happened because I see that every single day.
Yeah.
And so I have a different belief system. And as such, I come to the table with my patients with a different belief system. And this gets really, we just got a little esoteric and wonky here, but this is just as integral as, this is why I also use the data. I believe in both of them are just as powerful and important to the conversation, not one over the other. So I don't know if that helps.
No, I mean, I think if anything, it just gives me more confidence because I think that's where I am. I'm clearly not as educated about all of that stuff as you, but I have switched my mindset to have a belief that I'm going to change my lifestyle. Like within the first couple of weeks, I went full on vegan, for example, right? And I mean, my list of things is more than 50 things long that I've done at various times. And I guess it isn't all evidence-based, yet I still do monthly labs with my naturopath, like you were just explaining, to admit, right? And I change treatments or quote protocols then based on what those show. But there's also some just belief from me that, yeah, this will help me, right? Like I have done a ton of trauma work myself, emotional trauma work, and I consider that a huge part of my journey, where a lot of people would never consider that part of a cancer journey, other than like keeping you from committing suicide, maybe, right? But not from a healing aspect. So thank you for that answer. I think that is a huge part of your approach underneath. And I appreciate you just giving me that extra confidence myself. Thank you.
Eric, I really appreciate you. Thank you.
Okay, I think we've got 4 minutes. I have 2 questions, but I'm going to prioritize.
Okay.
we started out this conversation early on where I said, hey, we're going to talk less about proteomics and genomics and transcriptomics, right? I'm going to bring us full circle to that. Some of our patients have had quite a bit of testing, diagnostics testing. It's also worth noting that we have a relationship with a company called mProbe that will do proteomics for free for our patients. Yes.
Wow.
So given the whole, labyrinth of various testing out there, and that can include, genomics, transcriptomics, and proteomics, but also functional testing. What is most useful, or what is most complementary to your approach? What do you pay attention to most, if anything?
Well, I look at the metabolomics. I like to see what pathways are likely driving the train. So, I'm looking to see if this is, my gosh, 70% of cancers today we're finding are actually driven by PIK3CA. So that's a big one. If you don't address the metabolomics, if you don't address that, you're never going to get this patient out of trouble. Some of these particular methylation mutations, ATM, Lynch, GATA3, MLH1s, MSH6, BRCAs, all of those, they're not set in stone, but they potentiate things because they're very difficulty at methylation issues here. So then testing, is my patient hyper or hypomethylating? So I can do deeper evaluation to know if I'm going to need to upregulate or downregulate, or kind of just modulate that process. Things like, I'm trying to think of some examples of certain SNPs that you just kind of realize this is KRAS and BRAF. Huge examples. These are extremely aggressive and extremely recurrent cancers. And yet we have really amazing tools to target them outside of standard of care.
So also just neuroendocrine disease.
Yes. Yeah.
So we have some patients that are dealing with that.
Yeah.
Anything you can do for, okay.
So I've got to date, I've got at least 6 patients all over 15, 20 years with pancreatic neuroendocrine, that are cruising along, still there. And what we do is we dig deep. We look at chromogranin A as our marker of choice. We're always watching, making sure their calcium levels are stabilized. We're looking at their thyroid, their prolactin, their insulin levels. We're looking at all the endocrine hormones, right? We're making sure that those are constantly adjusted accordingly. We are making sure that these are patients that are very, very susceptible to metabolic changes, to stressors, to too much carbohydrate. These are also patients that are very susceptible to toxins, endocrine disruptors. So our patients also get worked up. I didn't have this on the list, but they get a full tox panel. They get worked up for glyphosate in particular, especially if they're blood cancers. Those are things that we definitely make sure that we're continuing to clean out the house. So neuroendocrines, they can live long, healthy life and die of something entirely different. And that's always my goal. They are tenacious though, and you have to stay on it. And so I want people to understand this becomes a lifestyle, and it's not an event, and that there may be no endpoint, but it doesn't take away your quality of life. I don't think anybody would ever look at my life and think, because even though I've dealt with the ovarian piece, it's kind of morphed into a lot of these neuroendocrine over because of my collection of other autoimmune patterns and other things. So I'm constantly tending to that field, and I do that with my patients as well. So it's, I love these types of tests that can give us the information to know where can we leverage our tools? Where can we bring in these tools to change these outcomes? And it's easy to see the changes, both in how the patient feels, but also in what the labs show, or even what their tissue assays. So we might repeat a tissue or a blood biopsy 6 months later for someone who was KRAS when they were working with us, and after high dose IV vitamin C and maybe a course of ferroptosis, suddenly they're not KRAS expressing anymore. It's like those are the types of things we can put enough pressure into the system to even change those genomics pretty quickly. So I think that there's so much hope on the future. I think that what I tell people is I feel like so much today, all these tests we do, these proteomics and all these testing, it's like a 2-year-old with a Maserati. They do not even understand how powerful the tool is. They do not know how to understand and translate what that data means. And they don't even understand how many tools can target those, from standard of care to off-label drugs, to nutraceuticals, to supplements, to herbs, to dietary and lifestyle modifications. It's incredible what it opens up for us in our toolbox.
Yeah. I don't know if you've spoken to Boston Gene, but if you're not connected to them, happy to make an
Love
introduction.
to meet
I
them.
think
Yeah.
that there's a real opportunity as you talk about your database,
I love
and there's a very data-driven company. They approach sequencing in a different way, and so anyway, if you want to pursue that, just let me know. So
Thanks, Brian. I'd love
two
that.
plugs. I want to be mindful of
Yep,
the
we're good.
time
We're
you give
good.
us. Very, very generous. How do our patients get a hold of you? I think you've shared some amazing information.
Thank you so much. It's been a huge honor, and probably the best place to follow what we're up to from the Integrative Oncology Hospital and Research Institute we're building on a 1,200-acre regenerative organic farm, which we didn't even get to talk about, to the education platform, to the data platform, to the lab we just opened in Arizona for a product development lab and mitochondrial respiration lab and metabolomics lab that we're opening up for research purposes. There's a lot of things we're up to. There's also places where I'm presenting all over the world, books I've written, interviews I've had. I've got a podcast that you might be interested in listening to, Metabolic Matters, for some really interesting guests that go deeper dive into these. So follow best at mtih.org, which stands for Metabolic Terrain Institute of Health.org. And I really hope I gave, you're welcome if somebody has some direct follow-up questions for themselves. I'm happy to kind of put you on the right path. You can email me at Nasha, Nasha, at mtih.org. So really, really lovely to be with all of you. Lots of great commentary, conversations, and direct private messages as well on the chat. So really, really grateful for your time.
Awesome. Well, we can't thank you enough, Nasha. And just a reminder to our community, we are a donation-based organization. And so if you found this useful, we would certainly appreciate a donation. You can go to our website, cancerpatientlab.org, and hit the donate button, and we would appreciate that. Nasha,